Hello. How are you doing this week? We are going to talk about abstracting for imaging services using ICD-10 PCS. As you probably know, virtually all hospitals have imaging centers right in there. Okay, so remember, ICD-10 PCS is only used for services provided by the hospital, their imaging department, to patients who are inpatients admitted into the hospital. So you may have had occasion to see a patient being taken down from their room in a wheelchair or on a gurney and taken down to imaging so they can get an X-ray or an MRI or a CT scan or whatever. So these are the services for which these coding skills will support. Are you ready? So first, we're going to start out with very important definitions, if you will, of imaging types. Now, some of these, you know what you know. And remember, the fact is, you don't have to know how plain radiography works because you are not prescribing it. But you do have to know that plain radiography is the same thing as an X-ray. Because generally speaking, the documentation will say X-ray. But, excuse me, but it's important that you understand the full scope of what is going on. Okay, so these are terms with which you need to become familiar. Now, almost everybody is familiar with plain radiography, also known as X-ray. Okay. Fluoroscopy is a totally different type of imaging that uses radiation to capture it's almost like a screen capture like we do, but it works in real time and uses that radiation to enable investigation of things like really small capillaries or small arteries so they can track where something is um, in in a way that they might be able to then treat that artery. Just yesterday, I was doing research on prosthetic prosthetic artery embolization. And now we're talking about an artery that goes into the prostate in a male person. And the embolization is they're going to put something in there that's going to obstruct that artery. It's to cut off the blood flow to a tumor. Okay. So they use fluoroscopy to make sure that they're tracking the correct artery into which they will then put microspheres, which is what they're using to create the embolization or the obstruction. Okay, so it makes it glow. It's really interesting to see on the screen. Okay, fluoroscopy. A CT scan. Did you know that that stands for computerized tomography? Well, you do now. And again, this is what we keep talking about with regard to alternate terminology. You may always call it a CT scan, okay? Some people call it a CAT scan. Some people call it computerized tomography. You don't know what it's going to say in the documentation, but you have to know that a CT scan, a CAT scan, and a computerized tomography are all the same exact thing so that you can code it accurately. Okay, the same thing goes with MRI, magnetic resonance imaging. And then, of course, we have ultrasound, which is also called sonography, which is also called ultrasonography. Yes, because why? Because it would be way too simple to have only one word to describe one thing, right? The point is that you must be able to identify the appropriate or the proper type of imaging that has been done. Remember, coding is only happens after it's done, not with the order, only after it's done. So that means you have to read the radiologist report as well as the documentation from the physician who ordered the test. Okay. You also have to have a sense of what the differences between these types of imaging are, so you can make sure that the ICD-10-CM diagnosis code is properly supporting medical necessity for that specific type of imaging. Okay, now this is an important issue for medical coding specialists to pay attention to, because there have been instances where an MRI was done when an X-ray would have accomplished the same thing, only MRIs are like 3 times the cost. Or they said they did an MRI and an X-ray was absolutely much better. Okay. So yes, we are the investigators because we are also on the hook for the fraud. All right. The fraud doesn't happen yet if the physician orders the wrong type of imaging. The fraud doesn't happen when the wrong type of imaging is used. The fraud happens when the code for the wrong type of imaging is placed on a claim form seeking money for the wrong procedure. Now, don't get nervous, because we're not asking you to make these decisions or these medical decisions. However, it is part of your responsibility to make certain that you are understanding what is happening and why. Now, here is the best idea. And you only need to go do this if you get a job coding for an imaging center, okay? But it also supports what I've been talking to you about over the last month or so, that having a good communication and a good relationship with the physician, and in this case with the radiologist, who is also a physician, by the way, so you can ask the question to learn. Okay. And that might be, well, why would an MRI be too much and an X-ray sufficient when the patient has a complaint of back pain? Okay. Or why an MRI versus a CT scan? All right. Now you can also Google this, and remember Medline Plus, which is part of the National Library of Medicine and the National Institutes of Health, can explain these things to you. But what I want you to do is understand why you need to learn them. And again, this is not an issue of replacing the physician or second guessing the physician. We are part of the same team. Maybe the wrong box was checked off. Maybe it was a human error, a mistake, but you don't want to continue that error and make it worse by creating fraud. So, and I mean, I find all of this fascinating, honestly. You may not, and you may never have to code imaging except on the national certification exam. But the fact is that every aspect of health care has an impact on us personally as well as professionally. That's one of the things I love about this. So remember that spending a little time researching why a CT scan would be used versus an MRI. What do the two different types of imaging give the radiologist, give the physician? What details are provided by one, not the other? When is it better to have a CT scan than an MRI? And remember, better for you to ask these questions and learn so you can code it accurately than for the Office of the Inspector General to come in and ask these questions. Okay. Now, the next thing that you need to know in order to find the correct character in reporting ICD-10 CPS, PCS, PCS, procedure coding system, okay, is the contrast. Now, you've had CPT coding already, and I think it's very important that you remember when you're reporting imaging from CPT, do you remember this? Is there are things like CT scans and MRIs that will offer you 3 codes for the same anatomical site. And it'll be with contrast, without contrast, or without contrast followed by with contrast. Okay, do you remember that? All right, well, in PCS, you not only have to know with contrast, just contrast, you have to know the specific media, the specific type of contrast material that was used. So it's not enough to know with contrast. You have to look at that record. You have to go through that patient record and look at what was injected into this patient to create that contrast. Was it high osmolar or low osmolar or something else? And remember, if you choose other, they're going to want an answer. Okay, so let's look at high osmolar and low osmolar because these are things that we can address. You can look in and see what contrast media was specifically used. Now, knowing this, if it's not already happening, you can make sure that your imaging techs and imaging department understand that this needs to be specifically in the documentation. It's not enough to say contrast material was injected into, but that you need to know, and you can tell them high osmolar or low osmolar, or you can say, I specifically need to know, which has got to be somewhere in the patient record anyway. Remember, every single chemical, every single medication has to be tracked through a hospital. So somebody knows, all right? You may have to look for it in the patient record, in the order, in the receipt from the pharmacy that was sent over to the imaging department. Okay. But having a conversation with your imaging department personnel is going to make your future life much easier if you can get them to just designate this for you. If they don't know, then they need to designate the specific name, either the generic name or the brand name. So you see here, I gave you some examples. High osmolality, okay, osmolality is diatrizoate sodium meglumine would be the generic name with brand names of Gastrogaffin, MD Gastroview, and Cystographene. Okay. Now remember, you could say, well, how am I supposed to know that? Well, because you have a computer with Google. Come on. You have, drugs.com. Or you can contact the pharmacy in the hospital where you work and ask them. But like I said, there should be documentation within the patient's record showing exactly what was given to the patient. This has to be for continuity of care, because what if the patient has an allergic reaction? How are you going to go what not to give him next time? Okay. All right. So this is very important. And I strongly recommend that should you get a job working for an imaging center, that you have this conversation with them if they are not already documenting it, or find out where you would find it in the patient record so you can go and check it out. Okay. But this is an important piece of information, not only required for the record, for the reimbursement, but required for continuity of care. Because like I said, if the patient has a reaction to it, we need to have that documented and moved over to allergic to meds. Okay. So therefore, it is part of your responsibility to make sure you can differentiate high osmolar from low osmolar. And again, if you just put in other contrast, they're going to require a notation that states what that contrast is. This is like in diagnosis coding. You can't just pick code unspecified, because that's not only a danger to the reimbursement and revenue cycle, because you're not getting paid for unspecified. Really? You don't know? You're going to operate on this patient, but you don't know what's wrong with them? Come on. How scary is that? But for continuity of care, this is incredibly important. You need to learn about this. You need to find out not why you would choose one or the other. Again, you're not replacing the radiologist. You're not replacing the ordering physician. You are in charge of interpretation. And the choices you have in this, for this character, in this ICD-10 PCS code, is going to require you not to just know with contrast or without, but is it high osmolar or low osmolar? Okay? All right. You have questions, concerns, confusions? Email me and I'm happy to discuss it. Okay, so we have one case study to go through. All right. And this patient's name is Scott Pepper. All right. His diagnosis on admission to the hospital was malignant effusion, dyspnea, history of metastatic bone disease, small cell carcinoma of the lung, and hepatic metastasis. Oh. So what does that mean? That tells us he has lung cancer that has now metastasized to his bone and his liver. He has effusion in his lungs that is cancerous, and he's having problems breathing. Yeah, well, that would be normal. Okay. I'm going to read, you read along with me, okay? And by the way, just as a secret, when you're doing this, when you're practicing these case studies, find a place and read it out loud. It helps your ears to augment your eyes with your brain as they kind of team thing, a group project. Okay. This 71-year-old white male was admitted for evaluation and management of his rather large, right-sided, remember, always right side of the patient, okay, right-sided pleural effusion. That's fluid in his lungs, okay, and dyspnea, problems breathing, difficulty breathing. He has had somewhat of a dry cough. He has had somewhat of a scattered bone pain syndrome. He denies fevers, chills, or sweats. Okay. All right. Past medical surgical history. See progress notes of Dr. Hammond, now part of this record, October 23rd, 2012. Medications at home, he was on Prilosec. It's for the, okay. Tenormin, Hitrin, Dioxygen, and Meggrace. He's allergic to iodine dye. Important to know in the imaging department. Non-contributory social history, non-contributory family history, non-contributory review of systems. He has a blood pressure of 140/70, pulse is 80, and regular respiration is 20, slightly labored, and he has a normal temperature of 98.6. Any observations for HEEN? T will be the throat, okay? Head, eyes, ears, nose, negative, 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 negative. Good job. Okay. Mouth, tongue, pharynx, negative. Neck, no jugular venous dissension or Brut's, supple. Lymph nodes, negative in all groups examined at this time. Chest, dullness on the right side, 3/4 of the way up, clear on the left. Cardiovascular, distance S1 and S2, no murmurs, gallops, or rubs. Abdomen, slightly obese, no masses or organomegaly. Genitalia, not done. Rectal, not done. This man has enough going on, really. Okay, extremities, no clubbing or cyanosis, but he did have 21 pedal edema to the knee, slight pitting. There's fluid in the tissues of his leg. Okay. Just a note for clinical documentation improvement. Does not say which side, right or left. Okay, but we're not going to code that today because that's part of his signs and symptoms of what he's doing. And right now, today, we're working in the imaging department, so it's okay. But again, these are the things that you have to look for, no matter what your job, no matter who you're coding for. Okay, superficial varicosities, skin dry, no rashes, neuro, central nervous system intact, and he's anxious, and yikes, who wouldn't be? Seriously. All right, chest x-ray. A chest x-ray was done. Large, right-sided pleural effusion. Bone scan of October 2012 showed diffuse skeletal metastasis. Remember, metastasis is the cancer has spread from another part into, okay? So skeletal metastasis is the cancer. We already know he has lung cancer, and that has now spread to his bones. All right. Laboratory data, ProTime and PTT normal, platelet count normal. Chemistry is unremarkable except for total protein of 5.8, albumin 2.6, total CO2 content 33, calcium 7.9, and alkaline phosphatase of 210. Hemoglobin 10.6 with a white count of 10.1. Okay. Note, thoracentesis fluid from April the 3rd, 2005, positive for malignant cells consistent with non-small cell carcinoma. Okay, so, wow, this gentleman was diagnosed with non-small cell carcinoma of his lungs back in 2005. That's 17 years ago. This is truly an excellent showing of how our healthcare industry has improved. Okay. All right. Thoracentesis. Remember, thora for the thorax, centesis is the pulling out of fluids. Remember when we did obstetrics, amniocentesis, amniotic fluid, centesis, extracting fluid. Okay. This is why we made you take medical terminology and anatomy and physiology before you came into coding, right? Okay. Assessment, diagnosis as above. Plan and recommendation. They are recommending that a tube thoracostomy be done. They're going to put a tube into his lungs, and after fluid is drained adequately, a pleurodesis. Okay. Now, I want you to work on this on your own. And the next 3 slides have the codes, the answers. Okay. So you're going to need 3 codes. There you go. Okay. I want you to close your eyes. 1, close your eyes. 2, close your eyes. 3. And you can open your eyes so I can say, if you have any questions, please contact me. Please email me and ask me your questions, or email me and say, I'm really confused. What does this mean? Whatever it might be, I am there for you. I will reply to you within 24 hours, and I'm in there 7 days a week. Okay. You are not alone. I'm right here by your side. See? Okay. Have a great day and stay safe.